Good morning. My pleasure to present urinary issues in patients with Parkinson's, and then we'll follow, as I understand, with questions. Is that correct? I want to keep this informal and at a high level, starting with a list of topics that I want to cover. A brief mention of what normal urination is, a realization that changes in urination are common as we age, and some of the classifications of abnormalities in urination that are useful for diagnosis and treatment. Urologists are famous or perhaps infamous for blaming everything on the prostate. So I'll talk a fair amount about that, but half the population doesn't have a prostate, so I don't want to be too biased. The symptoms that bring most patients to want care are more along the lines of overactive bladder, frequency and urgency of urination, and a manifestation of that that's disrupted to sleep nocturia, or getting up at night to urinate is very disruptive and often is the symptom that brings patients to get treatment. Urinary incontinence, especially in women, and then kind of the end result of progressive worsening of urinary symptoms may be the inability to urinate at all or urinary retention. All of these can occur in the setting separate from Parkinson's disease, but their management and diagnosis is more complicated in patients with Parkinson's disease. So we're going to try to mesh something that's otherwise relatively common with the audience today most interested in. And then what some treatment options that may be more desirable or less desirable in patients with Parkinson's disease. Next slide, please. So after we're potty trained and until we're in late or middle age, we don't think very much about urination. It's almost automatic. And really the bladder is responsible for storing urine and to protect the health of the kidneys that should be at a low pressure and emptying when we want it to and not leaking urine out before we voluntarily want to go to the bathroom. But then when that occurs, we have to relax the sphincters or open up the outlet and allow the bladder to contract and push urine out. It flows out until the bladder is empty. And it seems simple, but the next slide, you can't talk about neurologic diseases and the function of the bladder without a more complicated slide, which is next, right? So the brain, like potty training is the brain inhibiting the bladder from emptying when we don't want it to. And it's very important in that, but it kind of happens in the background after those neuron routes mature. And then, as I alluded to, at rest, we want low pressure in the bladder so there's not damage to the function of the kidneys. It's all under complex neurologic control, which is why Parkinson's and to a degree aging affect our urinary habits. Next slide. So age-related problems with urination are very common. We blame enlarged prostate on a lot of those symptoms for men, but regardless of gender, the bladder loses its flexibility as we age. It has less elastin, and the type of collagen changes. And you can think about that, our skin changes, and that's very visual as we have changes in the way our facial appearance is related to some of those proteins and fibers within the support structures of the face. The same thing, not quite as visible, is happening to the bladder, and the storage capacity of the bladder becomes less. Even without that, more frequent and urgent urination occurs more frequently and commonly as we age, and we sometimes have no explanation for that. And so we label that idiopathic, meaning we're idiots because we haven't really figured out the pathology. But we can market treatments to that if we label it as overactive bladder. So we have a pretty good idea what normal frequency of urination is, and there are medications that can be used to decrease the frequency of urination, especially if it's bothersome. The frequency of urination is determined by at least two factors. One is, what is the capacity of the bladder? How much can it store? The other is, how much urine do you make? And there are many things that occur more commonly as we age that change the amount of urine that we produce. Many will develop heart disease, for example, heart failure. They'll accumulate fluid in their body, and they'll need a diuretic to help get that fluid out. More volume makes more frequent urination. Sleep apnea, we talked a little bit about sleep studies. Sleep apnea is a very common cause of nocturia, so more frequent urination at night. And, we can treat the prostate and miss the real problem in urology because our history doesn't focus on your sleep habits like it might happen in the neurology clinic, right? So sleep apnea treated can dramatically improve nocturia. And then, that happens both in men and women. Women have the risk of pelvic organ prolapse. Dropped bladder is what a lot of patients will call it, usually as a consequence of childbirth, and that can affect urinary efficiency. It can make it more difficult to empty the bladder and may be associated with more frequent urination. So all of these factors that affect our urination occur more commonly as we age, and as such, more commonly in patients with Parkinson's disease. Next slide. We may, if you come to the urology clinic, we may ask you to grade your urinary symptoms. This is an example of the International Prostate Symptom Score, and it helps us determine whether your treatment is actually effective or ineffective. On number 7 on this, you see is nocturia. I like nocturia because it's a number that we can compare today to 3 months from now after you've been on therapy. Did it get better or did it get worse? But most importantly, how much does this bother you? Because every treatment has some side effect or risk. And if there's not an impact on your kidney function and it doesn't bother you, you may not need any treatment at all. Next slide. All right, so let's blame the prostate. So enlargement of the prostate among men is almost unavoidable as we age, though it does not inevitably cause urinary symptoms. As the prostate enlarges, the channel through which we urinate, the prostatic urethra, gets obstructed or blocked by that growing tissue. This will decrease the caliber of our stream, will take longer to empty, and if you go to a Mizzou football game and you go to the trough, you'll notice that it takes you a little bit longer than the person on either side of you. No big deal, right? But if you incompletely empty your bladder, you may have an increased risk of infection or bladder stones. You're starting with the tank half full. You never get to empty, so the next time you urinate happens sooner. So you have more frequent urination, and that can spill over to the evening, so you get up at night to pee. The bladder also has accelerated loss of its elasticity, becomes less compliant, and responds the only way it knows how to, which is squeezing. And so you get more frequent and urgent desire to void. And as I alluded to, this can spill over to the nights. Next slide. So what do we do about this? Well, and for most patients, nothing is necessary. As your bother is low and there's no medical consequences, observation is appropriate. Generally, it gets worse over time, but not inevitably. The risk of serious medical consequences are low, not being able to urinate, needing surgery, probably about 5% of patients at 5 years, so 1 in 20. That does not compel us to treat every patient. Sometimes just changing your habits keeps you away from medications or surgery, restricting fluids before bedtime, double voiding, really working hard to get your bladder empty, do it twice before you go to bed. We underutilize physical therapists for pelvic physical therapy. They can really make a big difference in our urinary habits and improve recovery from surgery if necessary, or delay the need for surgery. It takes a special physical therapist with knowledge in this field to be good and really help patients, but we underutilize it. We have a lot of medications, and then the joy for the doctor is the surgical interventions, but relieving obstruction, helping someone from not being able to urinate to urinate is very rewarding, but it's a small percentage of patients with enlarged prostate that need and get surgery. Next slide. So the medications, the classic is tamsulosin, also known as Flomax. It relaxes the smooth muscle. Sometimes we get lazy with words and say it shrinks the prostate. This medication and all of the ones in the first box work by the same mechanism, and they can be problematic in patients with Parkinson's disease because they're associated with lower blood pressure and orthostatic hypotension. So you get lightheaded when you stand. And we've heard in several of the presentations about autonomic dysfunction, where our nerves don't signal the muscles in the blood vessels to tighten and keep us from fainting when we stand up. These medications make that worse. The 5-alpha reductase inhibitors, of which finasteride, also known as Proscar, was first to market and is most commonly used, actually do shrink the prostate, takes longer for it to work, and the response to treatment is slower, but it has fewer side effects, although about 10% of men will stop using it because they get enlargement and tenderness of their breast tissue, which is not desirable for most men. But it is an effective medication to be used to shrink the prostate. Tadalafil, I didn't have enough time to do the sexual dysfunction in Parkinson's talk, maybe next year. Tadalafil is the generic name for Cialis and is most widely known as a treatment for sexual dysfunction or problems with erections, but it can be used to treat symptoms from enlarged prostate, and it's the only drug in that class that's approved for that purpose, in part because it's long enough acting that it will actually work. If your symptoms are frequency and urgency, then we rely on different classes of medications. The group of antimuscarinics, or sometimes known as anticholinergics, will weaken the bladder and cut down on spasticity. They have a lot of brain side effects. And the urologic community is getting caught up to the psychiatric and neurologic community. These are bad for elderly patients, associated with higher rate of dementia and acute cognitive decline and psychosis when you first start them. Perhaps one of them has less of that. That's trospium, which is designed to not be absorbed into the brain. But in general, although we've used these medications for 50 years, we're trying to stop it. And if in Parkinson's, there's a lot of urgency and frequencies, these can be very helpful, but we can undo the work of the psychiatrist and neurologist if we're not careful. Fortunately, there's a new class of medications, the beta-3 agonists, which avoid those cognitive or brain side effects. There's no generics yet, so you might need the help of your specialty pharmacist to get these at a reasonable cost. Mark Cuban has been lobbied to get this for our patients. soon to be generic, hopefully, but maybe there will only be one manufacturer and the cost won't go down. One advantage of these medications is they, as a side effect, increase blood pressure. So some of our patients with low blood pressure as a result of Parkinson's, this medication class makes a lot of sense. Okay, next slide. Some patients need surgery to treat symptoms of an enlarged prostate. And this is affectionately called the Roto-Rooter. It's not very good marketing, but it's very descriptive, right? People know what you're talking about. You're opening up the pipe, and to a certain degree, urologists are glorified plumbers. The classic treatment is a TURP, transurethral resection of the prostate. That's depicted in the upper panel. It uses electricity to remove the blocking prostate tissue, electricity to stop the bleeding. It's a mechanical approach to the problem, and it works very well. But urology has been searching for a better mousetrap for 50 years, and most of them come and go because they don't work as well or last as long. But a list of the currently available alternatives include UroLift, which is a trade name for scaffolding that opens up the prostate a little bit, microwave energy, Resume, which uses steam energy instead of electricity, aquablation, which uses hot water injected into the prostate, and HOLEP, which uses a laser. They all work. They have advantages and disadvantages, but the idea is to relieve the blockage caused by an enlarged prostate. Next slide. So overactive bladder, shifting gears a little bit, is a generic term we use to describe urinary urgency and frequency, and may be associated with incontinence of urine. It can be due to an enlarged prostate. It's more prevalent in women, and the list of causes include neurologic conditions such as Parkinson's, multiple sclerosis was mentioned earlier. All of these diseases can affect the way the bladder responds to filling and gives you a more premature. We may not know the cause. And again, behavioral modification, physical therapy may be helpful. Sometimes we need diapers, pads to control urinary leakage. Sometimes a catheter, which generally urologists consider an indwelling catheter a failure of coming up with a good treatment plan, may be necessary because it's the best option. There are medical management. We alluded to those medications, the anticholinergics and the beta-3 agonist. And there are some surgical treatments. There's neuromodulation. We didn't really talk much about deep brain stimulation for Parkinson's in this year's conference. We have a similar type of principle for neuromodulating the bladder. There's two competing brands. And then there's a lot of new peripheral nerve stimulation that kind of tricks the nervous system into telling the bladder to be less spastic. And then I do, in my practice, a lot of Botox injection. And it can be very helpful. It's a little bit more invasive mechanism of getting the Botox into the muscle layer of the bladder. We have to go with a cystoscope through the urethra into the bladder. But it can be a very effective treatment for overactive bladder. Next slide. So I already alluded to the concerns about safety of some of these medications in the management of overactive bladder. We also worry that if we're too good at relaxing the bladder, you won't be able to pee. And generally, but not absolutely, it's better to pee more frequently and more urgently than not to pee at all. Okay. My sense of humor is getting through it. All right. Next. Got 10 minutes left. So I alluded to nocturia, or getting up at night to urinate. We talked about fluid imbalance. Sometimes we create a vicious cycle. We give you a medication to relax your bladder. That medication has the side effect of dry mouth. So you drink a bunch of water. So if we're doing our job well in the urology clinic, we may ask you to do a voiding diary, where you keep track of how much you drink and how much you pee. It's essentially a free test. There's no cystoscope or needles involved, and it will tell us a lot about your fluid intake and fluid output, how much capacity your bladder has, and we may identify something non-invasive that we can do differently. I had one patient that in the last 2 weeks who had 7 liters of fluid intake, most of it iced tea. I'm like, I think I know why you're peeing all the time. Can you change your habit? Maybe he might need a psychiatrist to change his behavior, not a urologist. Okay. Constipation, which, as I understand it, is very common in patients with Parkinson's disease, is a contributing factor to urinary frequency, including nocturia. Some of it is just a mechanical view of the world. The pelvis is only so big, and if you have constipation, your rectum fills up some of that space. The bladder can't have as much of its own space, and you'll have to pee more frequently. Some of it's more sophisticated. The nerves get signaling or lose their signaling over time. But the combination of constipation and urinary habits is first kind of understood in urology by the pediatric urologist, but it definitely impacts patients with Parkinson's and other patients as they age. Occasionally, we'll use a medication to decrease the amount of urine you make at night. That's DDAVP or desmopressin. It tells the kidneys to let less water out. And so you have a better chance of getting through the night. It is not free of side effects. You get fluid retention as a consequence. You have to pee that fluid out the next day. And it can dilute the sodium level in your blood. Medically, we call that hyponatremia, which can be associated with brain dysfunction. So, right, all of these things come together with a lot of treatment options, but not necessarily much therapeutic safety window where you can tip things out of balance with one medication if you're not careful. Next slide. And finally, on women with stress urinary incontinence, we get nervous about doing surgery on patients with Parkinson's because surgery in general is irreversible, and we're not exactly certain how people are going to respond. But stress urinary incontinence, we should have a low threshold to offer effective treatments for women. Most commonly deployed are mid-urethral slings, which are kind of a hammock for the urethra and prevent urine from leaking out. But of interest lately are these bulking agents that are minimally invasive, can be done in the clinic, and prevent urine from leaking out of the urethra when you cough or sneeze, and are generally effective and safe. But we should not exhaust our other treatment options, which are more conservative, like behavioral modification, physical therapy, and potentially some medications generally used off-label that increase the tone in the urethra and lower the likelihood of stress urinary incontinence, which is largely in the realm of women and not men, unless that man has had prostate surgery, the removal for cancer, or TURP for enlarged prostate. Men generally do not have stress incontinence of urine. Okay, next slide. In the worst case scenario, and where we probably get in the most controversy in managing patients with Parkinson's, is if you can't pee at all. So a urinary retention, which can be detected by a bedside scanner, catheter insertion, or a CT scan. And this depicts a person with a very large bladder, wasn't able to pee. A urethral catheter is our first step of management. Sometimes we put the catheter through the front of the abdominal wall. That's a suprapubic tube. Or if a patient is able, they can catheterize themselves 3 or 4 times a day to empty the bladder. will initially decompress the bladder, then start medications, and about half of patients will be able to avoid surgical treatment. But most people who can't pee, most men who can't pee, will be looking at the prospects of surgical treatment to relieve the obstruction if we can identify that it's from the prostate. And that's where we go back to the TERP or its cousins, so its competitors. Next slide. So what is the impact of Parkinson's on these urinary symptoms that are very common as we age? Well, at diagnosis, more than half of Parkinson's patients will have demonstrable urinary symptoms, and they may or may not be due to Parkinson's. They could be due to enlarged prostate or pelvic organ prolapse or some other condition involving the bladder. If a patient does not have urinary symptoms when they're diagnosed with Parkinson's, they're likely to develop them over time, usually within 5 years. And again, is it due to the Parkinson's, or is it just that age caught up with them? The inevitable that was going to occur is also occurring. Most bothersome or most commonly reported is getting up at night to urinate, frequency, and urgency. So more of the irritative voiding symptoms are what bothers patients. They seem to be overrepresented compared to patients with just enlarged prostate or just pelvic organ prolapse. So the neurologic component, the part of Parkinson's disease, is having an impact. I learned a lot about Lewy body and how it really affects, if you have Lewy body dementia, this effect on the urinary incontinence. I have to pay a little bit more attention in the clinic with that. And then the good news is most patients with Parkinson's are able to empty their bladder. Next slide. But our treatments, as I've alluded to, are more complicated, have a higher risk, not as clear benefit in patients with Parkinson's. So we sometimes do a more advanced testing before committing to especially something surgical. And this is when we may subject patients to urodynamics, where we measure the pressures and the flows and ascertain the neurologic function of the muscles around the bladder to try to make the most accurate diagnosis. In my mind, I always do this before recommending surgery. It's not absolutely necessary, but can be very useful. Next slide. When thinking about managing the urinary symptoms of a patient with Parkinson's, we want to ensure that they are having the best possible management of their Parkinson's disease by their neurologist. We can endeavor to adapt behavior. I think about the struggle that is caused by urinary frequency and nocturia if you're mobility impaired, right? It's real. And then the catastrophic scenario in my mind is you're getting up to pee, and then the light's not on, and then you trip over something and you break a hip, right? It happens all the time, unfortunately. Or let's say you cannot urinate and we put a catheter in, and now you've got a suitcase you're carrying with you everywhere you go. It can be devastating to your ability to stay at home and your mobility. And so we really have to maximize our medical management to avoid those problems. So beta-3 agonist and BPH for the overactive bladder is probably our best bet for most patients with Parkinson's, and BPH treatment with alpha blockers and finasteride or 5-alpha reductase inhibitors for enlargement of the prostate in the men, and cautious surgical intervention. That being said, a patient in urinary retention with an enlarged prostate, we worry about urinary incontinence after a TERP, but it's probably better to have leakage than have a catheter. So we can accept that. We just have to counsel appropriately and manage carefully. Next slide. There's research that suggests that deep brain stimulation helps urinary symptoms. I've not heard someone getting it just because of the urinary symptoms, but we can hear from the neurologists how they think about that. Botox into the bladder is very effective. at relieving overactive bladder symptoms, but again, it can be too good and you can't pee afterwards. You have to be prepared to do self-catheterization. Peripheral nerve stimulation has not been studied well in patients with neurologic diseases, but it will be. And then TURP if needed with caution. Next slide. So my take-home messages are avoiding symptoms are very common. They're common in general, but they're especially more common in patients with Parkinson's. We have to consider the other causes and not blame everything on Parkinson's disease. Accurate diagnosis that informs our treatment decisions may be more advanced than for someone who does not have Parkinson's and more invasive than someone who does not have Parkinson's. We really should use all of our treatment options, but be more selective. The effectiveness and the risk are impacted mostly negatively by presence of Parkinson's, and thus we have to rely on shared decision-making about what's the best thing for each individual patient.